Absorption refers to the transport of drugs across the membranes of mucosal cells in the gastrointestinal tract. A drug enters the gastrointestinal tract through the mouth and moves into the stomach through the esophagus. Once in the stomach, the drug dissolves. Acidic drugs are absorbed in the stomach because its acidic contents cause the acidic drugs to remain unionized, uncharged, for easy absorption. Alkaline drugs, which cannot be absorbed in the acidic stomach, pass through the pyloric sphincter into the first part of the small intestine and are absorbed there. Once absorbed in the blood, the drug molecules travel through the liver via the portal system. Some drugs are immediately metabolized in the liver. This is called first-pass metabolism. Others may be secreted back into the small intestine in the bile in what is known as enterohepatic cycling. Other parts of the oral dosage may be absorbed in the large intestine or fecally excreted. All of the drug dosage may not be absorbed. The drug molecules may bind to intestinal content, which prevents their being passed through the membranes of the mucosal cells. Or they may be broken down by bacteria in the ileum and colon.
Okay. What that video points out, it explains absorption probably better than I do, but it also brings up the point of the importance of reading our packaging and looking at, do we give this medication with food or not? Because the point there is that if it's meant to go with food, that will help it absorb more quickly because it'll carry it down to the appropriate place. Or if it's not meant to be given, it's meant to be given on an empty stomach because it binds to the food and stops it being absorbed. So it's a really important part of giving out a medication, being aware if it needs to be taken with food or not.
Yep. I always thought taking medication with food meant nausea.
Yep.
If you take it with food, you don't get nauseous. That's
Yeah,
not what I
but some
thought.
some foods will affect your medication. That's why they don't say don't take it with food. And it can because of the actual action of the medication on your stomach because it increases acidity. But the other ones, yeah, as it says, it needs to bind to that food to move on through the intestines, down through your, as it says, the pyloric sphincter into your intestines to be actually absorbed through your intestines lower down.
Lower down, yeah.
So, factors that affect absorption. So we've been talking about absorption. So there are drug factors. They talked about ionisation, right? If it's ionised, then it absorbs less or more effectively depending on the drug. Don't worry about molecular weight. Solubility is important. Soluble aspirin. If you dilute it, you give it, that's what it's meant to have. It's supposed to be given in a fluid because it absorbs faster. If we take it as just a tablet, it will reduce the rate that it absorbs that because the body has to break it down, then absorb it. So it's really important. Don't worry about those. Okay, so there are patient factors. So it depends on the route of administration. So you imagine the presence, right, of food in the GIT, as I mentioned before, the stomach, acidity, blood flow to the gut. If you've got a bowel obstruction, everything slows down. It reduces your blood flow. It reduces gastric motility, that action that squeezes it down through your bowel. You won't get that movement, so you won't get absorption. It might not be able to get right down. Not only will it not be excreted fecally, it won't get down into the lower bowel because it can't get past that obstruction. So we have to take that into consideration when we're giving a medication. If someone normally has a bowel obstruction, the first thing they do is make them kneel by mouth. So the other thing is bioavailability, right? Refers to the amount and rate of the appearance of the drug in the bloodstream after administration of the dose. That's the idea, is we get it into it's absorbed, it goes into your bloodstream, and then it's circulated around your body. So, if we're giving it orally, there's going to be a delay, isn't there? But if we give it IV, it's 100% bioavailable. The whole amount of that drug
Straight away.
is in your bloodstream. It's doing its job straight away. If we put it through the gut, there is a loss, and it depends on the type of drug, the structure of how it's made up, as to how much is lost. So, drugs with are poorly soluble in body fluids will have a lower bioavailability. So, something like, I'm just trying to think of a really good, we'll go back to our soluble aspirin, right? It's designed so you take it, it breaks down in the water and you drink it, which will make it bioavailable, or its bioavailability a lot faster. So it'll also be more effective into your bloodstream. If we take it whole, again, the gut is going to destroy a percentage of it, there will be less bioavailability. So you want to get the best effect from the drug that you take. The degree of compression and use of additives by the manufacturers can affect it, and they use additives to actually decrease sometimes the absorption rate of the drug. So it'll say if you decrease your absorption rate, because they want it to absorb slower, the bioavailability is less as well. But we'll talk about that a little bit further on as well. So distribution, right, is dependent on the membrane permeability, right? For a drug to enter an organ, it must permeate all the membranes that separate the organ from the site of administration. It sounds like a mouthful. So the membrane that separates it if you take it orally is your gut, is your intestine or your stomach, wherever it's absorbed from, depending on the medication. So it needs to get to your brain. So it's got to go into the bloodstream and it's got to travel. If you've got a slow gut, right, so you haven't got that peristalsis going on, it's not going to absorb it as quickly because it's not moving it. The membrane, the actual whole process of the gut slows everything down. Okay? So you need it. Benzodiazepines, benzodiazepines. I have trouble with that one, as you'll find with a few words. So think about it. Benzos are your Valiums, which are designed, right, to permeate the gut, will work fairly quickly. They then go to your blood-brain barrier, right? And they're useful in treating anxiety. So if you want to get, someone's anxious, we can give them a bit of medication really fast. And if it's a severe issue, they give it IV because bioavailability is 100%. But we give them to them orally where we can, and it will work fairly quickly, within 20 minutes normally, and start to slow them down. If it's a seizure, we'll give it IV, because it'll work within a few minutes and actually start to affect that patient. We don't want them seizing for a long period of time. So, like the blood-brain barrier, there is a blood-placental barrier, right? So we've talked about benzos going up to your brain. What's something that could affect your placenta? Think about when you give birth. They can give you
like pethidine.
Pethidine. It's a primary one. If you have pethidine, it reduces your pain.
Yeah.
What does it do to baby?
Knocks the baby out.
Exactly. So you get, baby comes out, they're stunned.
Yeah.
They're sort of a bit dazed by the world. They've been narcotised a little bit.
Nah. Yeah.
And so then the midwife will bag them, get them with oxygen going because it affects their respiratory ability, right? Because it is able to cross that placental barrier. Most things do. And that's why when we look at a drug and we're giving it, we ask someone if they're pregnant. Because in there, in the MEMS in particular, and Havard's has it too in some cases, not recommended in pregnancy. So we have to find out why. Sometimes it's specific to the trimester that you're in. Can't give it in third trimester or can't give it in first trimester. So it's really important that you know your patient if they're pregnant, and B, if that drug affects the placental blood or the placental barrier. And another video. As you know, I love videos.
Distribution is the process by which drug molecules enter the bloodstream, circulate through the body, and are transported to target sites of action. Distribution begins when drug molecules enter the blood from the liver, where they have been metabolized. The molecules then travel all over the body via the vascular and lymphatic systems. It is from the capillaries that the molecules are distributed to target organs and tissues, as well as to tissues where they will exert no action, for example, storage sites, sites of inactivation, and sites of excretion. The capillary wall is composed of a single layer of endothelial cells. The drug molecules diffuse across the endothelial cells of the capillary into the surrounding interstitial fluid and then into tissues. Because the drug molecules are delivered by the blood, the entry rate of a drug into a tissue depends on the rate of blood flow into the tissue mass, and the rate at which entry and exit of the drug molecules between blood and tissue equilibrates. Distribution may be uneven when there are differences in blood perfusion, tissue binding of the drug molecules, regional pH, and permeability of specific cell membranes.
Alright, that talks about the distribution of drugs through the body. So what are things that we have, other things we can take into consideration when we're giving a drug to a patient that would affect the cell or the membrane permeability, such as your capillaries or your arteries or your veins?
Age.
Right, you get older, things get harder, thicker, so therefore we have to take that in consideration when we're giving a drug. What else could be?
Weight.
Weight, good one.
Medical conditions that they already...
Absolutely. So weight, if you're larger, it's going to take a lot more to distribute it. So you think about what we do with children when we give a paediatric, we weigh them.
Yeah.
And then the dose is based on weight. And again, diabetes is a prime example. You get reduced circulation. So therefore, right, it's going to be harder. Yeah. So you're not going to get the effect that you want necessarily. So all considerations when we give a medication, as a nurse, yes, the doctor does take it into consideration, right, when he gives out a drug, but not necessarily does he get to talk to that patient and realise that they had poor circulation. Because he's seen them for 15, 20 minutes in ED. We get to talk to them while we're giving them their medications or while we're making their bed or giving them a shower.
Yeah, and we notice it.
You get a better assessment of them when they're standing up. So it's something to take into consideration, something to point out if we need to wonder why the drug isn't working properly. So doctor, you realise that they've got reduced circulation in their feet. Along with, and that's part of our assessment as nurses.
So Neville, sorry to butt in, why can't they give an injection, so say for diabetics that do have very poor circulation, like in aged care where it's almost at the point of amputation, why can't they just give them an injection in that site?
Right, because what happens is that there's nothing that can rebuild the blood vessels. When you've got poor circulation, it's not just that the blood can't get there. Over the years, the arteries have died, or the capillaries have died off.
Yeah, of course.
So there's no blood supply.
There's no blood supply there.
So
of course.
And then they also damage their nerves in their feet, so they can't feel anything. So they may burn their foot and not notice it. So the reason that they actually lose their feet is normally from an infection, a gangrene.
Yeah.
So they'll never feel that pain.
Anyway. Yeah. Makes sense. Sorry.
That's all right. Don't apologise. It's a good question. So I just did something. The main side of drug metabolism is our liver, and it's our kidneys as well. They're the two main ones. But we can also metabolise drugs in our lungs. Can you imagine
Inhalers and stuff like that.
About to ask the question, you've answered it.
Yeah.
Inhalers. It's really important that we consider that, where it's metabolised. So one of the reasons that doctors can tell you that you can take Panadol and alternatively you can take ibuprofen in between if you've got a really bad fever or you're unwell, is that they're metabolised at different places. So your Panadol's metabolised by your liver, ibuprofen's actually metabolised by your kidneys.
Yeah.
So you're not going to get your liver working overtime to metabolise a whole heap of drugs.
Yeah.
And they take that into consideration when someone's on multiple drugs.
Mm-hmm.
So liver metabolism is influenced by the enzymes whose activity can increase, causing more rapid metabolism, decrease in the liver. So how fast you metabolise something, how long it stays in your body, how long you maintain that bioavailability. Whereas, again, patients who are malnourished or suffer from liver disease, right, will have a reduced rate of metabolism. So there are enzymes that break down, and your liver helps produce your bile, and it helps filter everything. If it's not working properly, it's not going to filter it properly. It's not going to work properly. But this is also true for the young, and in some cases the elderly. Little babies don't have a developed liver.
Yeah.
And it's why we can't give them drugs till they get to a certain age, or medications. In the elderly, the same principle happens. They're not functioning as well as it used to. It's had 90 years of use. So therefore it's not functioning. So we have to take that into consideration. And when they come into hospital, they'll do a liver function test to see, and they'll take that into consideration when they're giving it. So metabolic function can turn an active drug into an inactive drug. If you're not processing it, if you're not metabolising it, then it's not working. You'll just excrete it. And that happens, and one of the prime examples, there are a couple of the antibiotics that they give that will change the colour of your urine. And they give that drug to some people, and all of a sudden it doesn't, there's no change in the colour. And they realise that their liver's not metabolising that drug and excreting it. So you have to be aware that it could build up in your system.
So it stores it in the...
It doesn't filter it, so it keeps it circulating in your body.
Yeah.
You don't get rid of it as effectively as you should.
So could that build up to toxic levels?
Yep.
Yeah.
You can get a build up in your system, and you don't want that.
Yeah.
So orally and rectally administered drugs through your GI tract, doesn't matter which end you go in.
Really?
No, it still goes through your gut. It absorbs at the same rate. I used to always tell my kids, and it's why they take tablets really well. You've got two choices here, guys. Either you take the tablets, or there's another way I can give it.
But I have to give suppositories to my daughter.
Yep.
Because she can't take oral tablets very well. The acidity, she'll bring it back up.
Yep.
So that's how my daughter has her medication.
So it works exactly the same.
At the same metabolic rate.
Yep.
Okay, I thought it was faster.
No, it's just there's a lot of people that think exactly that.
What about
It's
under the tongue too?
sublingually. That's a whole different kettle of fish. Yeah. But when you go through, it's still absorbed by your gut because it still goes in. But with the rectally, a lot of people think that it's absorbed faster. No, it's not.
Right.
Because it's still got to go through the same metabolic process. It's just processed in your lower part of your bowels.
Right.
So it'll still go out and be distributed in the same way.
Yeah, but it won't go through the stomach.
No. And that's why she's got to have it, because she refluxes when she takes medication.
Yeah.
And there are a lot of people out there that are like that.
Yeah, and it's not the same med, is it? It's not the same med. A suppository is not the same medication as what is taken orally. Because it's broken up through your bowel. It doesn't go through your gut first.
No, it's the same medication.
Right.
What's actually broken up in your stomach is what the medication's in.
Oh, okay. Yeah, I get it. Yep,
So-
I get it. Yep.
So in the suppository, it's just more or less, it's the more
It's a
pure
different coating.
form of it.
Yeah.
It's kept in a different
Coating.
compound.
Yeah.
than it is your gut.
Yep.
They make it so that your gut breaks it up and it releases it, because if you just put it in straight in, it'd destroy the actual product.
Yeah. Yeah. Okay. Yep. I get that.
So excretion, an important part. We need to get rid of what we put in. So drugs are excreted mainly by the kidneys, right? So we pass it out in urine. Some is done fecally, so it goes to the lower part of the bowel. It's going to go out in your feces. And some of the antibiotics, when your kids go to the toilet, you smell it. Penicillins, some of the penicillin. And some are expired by air. So what do you imagine that would be?
Breathing.
Ventolin, exactly. You take a puffer in, you breathe it in, it goes, excess
Out.
is excreted out.
Yeah.
So it's a good thing if you're in front of someone that's getting Ventolin, you can get a dose of Ventolin from them when they breathe out. Just be aware of that. It shouldn't be in there. And another thing, the important thing is impaired renal function results in decreased elimination of drugs. So if your kidneys aren't working well, you won't eliminate them as well, because you don't, simply your kidneys don't process it. One of the prime examples is ibuprofen, right? If you read the information on ibuprofen, it's nephrotoxic, right? So it actually damages your kidneys technically. It's toxic to your kidneys. So if it's not excreted, it can damage your kidneys. So I had an example of a doctor said to me, I want to give them some they'd give it some ibuprofen. I'd read up on my patient and realised he had one kidney. Said I had to go to the doctor and say, look, you realise they only got one kidney? And he went, oh, didn't click on that one, didn't think about that, because they give him ibuprofen.
What's the drug, please?
Ibuprofen.
Oh, ibuprofen.
Ibuprofen. Yeah, ibuprofen.
I don't know. But
Yes,
yeah.
ibuprofen. There's lots of different names.
Yeah.
Nurofen
Yeah.
as a trade name. So that child potentially has one kidney. There's a huge risk for that because they're going to excrete that more slowly.
Yeah.
So there's a chance that they could just do kidney damage.
Yeah.
And you read on the packet, it says if you don't have full renal function or full kidney function, don't take this medication, right? And it's the same as if someone's an alcoholic and has liver disease. Really, they shouldn't take Panadol because it's metabolised by your liver, and so you'll get a build-up of Panadol, and they won't excrete it properly because it won't distribute it out to the body properly.
So could ibuprofen,
Mm.
if your kidneys aren't working properly, could ibuprofen cause UTIs?
No, I doubt it.
No.
No. It's more likely to damage your kidney than cause a UTI.
Okay.
So, when we give out medication, they're governed by all sorts of things. So the policies. So we're talking about hospital policy and procedure. Who can give out? What's the maximum dose? Different hospitals can have rules about maximum doses. There are Queensland health policies that say that potassium's a classic. When I started with Queensland Health, we had a little 10 ml container. We drew up the potassium and put in the right amount. Mistakes happen. Potassium can kill. So now they give it out in a bag. So most you can give out is, say, 10 millimoles of potassium in 100 mils, or 20 millimoles in 500 mils. That manages the issue, but that's actually a policy. It's not necessarily the most effective way, but it is the safest way to give it. And there's a policy that says that the bags with potassium in must have red writing on them. So that's what governs medications. Drug schedules, so the S1s, S4s, S8s, all have different rules built around them. The elements of a valid medication order. 7 rights. Jade teaches you in the labs to go down your chart to check your 7 rights. Great idea. Good policy. And you will read down it, and that way you'll maintain your 7 rights, and you'll know that your order is valid. If something's missing, it's not a valid order, what would you do?
Don't get the list of the
don't administer the drug. What else?
Go to RN.
Go to your RN or ring the doctor.
Ring the doctor.
Yeah.
Yep. Well, no, the pharmacist can't change the order.
Oh, Jade said she can. Again, if you
Can't
can't,
override.
it can override. He can.
They can change an order if it's not the correct order.
Or it's
They
familiar.
cannot interpret what the doctor wants to give, just like we can't. The doctor is the person who has to clarify his own order. If the pharmacist can come along and go, he's put Maxil on, it should be metoclopramide, and he'll write metoclopramide, because that's the generic name. But he can't say, well, if the doctor's ordered 100 of metoclopramide and it's meant to be 10, he can cancel that order. He can't actually change it to 10. He can cancel the order, contact the doctor and say you need to write a correct order. Because a pharmacist can't order medication for a patient. Same as a nurse, a registered or enrolled nurse can't order medication for a patient. I can't even go without authority and say you need a Panadol.
Yeah, no.
Even though you can buy it at the supermarket, I can't say to a patient, here's 2 Panadol. In some cases, there are nurse-initiated protocols that allow you, in emergency, to give out Panadol or Panadine under certain circumstances. But, in saying that, you have to know those circumstances. So, a pharmacist is the same. He can't actually individually order for someone.
Okay.
He knows the drug. He probably knows it better than the doctor.
Better than the doctor. Yeah.
But he can correct the doctor's dosage and say you've given the wrong dose. But the doctor, at the end of the day,
But
has
can't
to
change the
rewrite
drug.
the dose.
Yeah. Yeah. Okay.
If they don't have the drug, he can suggest an alternative. So you have to be aware of any potential problems with that drug. So some drugs you give can cause, and they're cardiac drugs, I'm thinking of amiodarone, which is a drug you give IV for people that are having a failing heart. It helps improve the contractions of your heart. But the problem with it is it can cause arrhythmias in your heart. That can be another potential problem. So if you're aware of those, you can monitor that patient. They have to be on a heart monitor, and you can keep an eye on it while they're having the drug. And if they start to get an arrhythmia, you can turn the drug off and get the doctor there really fast. Or get your RN in that case. So you have to be aware of what routes a drug can be given. There are specific drugs that can only be given IV. Right? A lot of chemotherapy drugs, only IV. Amiodarone, the drug I just mentioned, can only be given IV. And the other things that talk about, we should be aware of the different classes. And on that sheet I've given you some of the classes of drugs. We have to know how to do calculations so we can give the right dose. Right? Including paediatrics, we have to be aware there's a difference. IV therapy, what do we have to do to give someone an IV dose of this drug? It is different from an oral dose because of the bioavailability. So we might have to give more of an oral antibiotic than we do if we give it IV. But when they manufacture it, they allow for that as well. And pain management is really important when we're giving drugs. I've got a little bit on pain management later on. Policies. So there are really 3 levels of policies to uphold. An example is there are state regulations. That's one of them, the Health Regulations 1996 and the Poisons Act 1996. And that's a really important one to remember for your assessments because it's got a really good definition of the role for nurses, the enrolled nurses, in giving certain medications. And it talks about SAs and things like that. And I think it asks that in one of your assessment questions. APRA, the scope of practice, or under AMNAC. It's a general scope of practice, but it gives you some idea. And the big thing is organisational policy, particularly for enrolled nurses, because it tells you what you can and can't do within that organisation. And you go from organisation to organisation, and it can all be different. So you have to know. And as an EN, you need to check on that. what drugs can I check S8s? Can I give S8s? Private to public's different. Aged care to acute's different. So just make sure you're aware of it. And once you've read them, you're right. The toughest people to have that would be agency. You'd have to check it every time you went.
Every time you went somewhere.
Yeah.
Yeah.
So storage of medications is really important, because if we don't store the medications properly, other than the fact that they can get stolen and misused, storage can affect how effective the drug works. So S4, an authorised person in possession of a restricted drug at a place of work must keep the drug in a cupboard, drawer or storeroom or other part of the workplace to which the public doesn't have access. Because they could steal it, or some little kid come along and accidentally pick it up. And it's a good thing to point out when we give, and you've probably seen it in aged care. I asked the group earlier today, who saw the person giving out the drugs leave it beside the patient's bed for him to take later? Right, there's 33% of our audience. Right? In the one yesterday, it was something like 70%. That's wrong. That's illegal. It's against the rules. It's against the scheduled rules. Yet they do it. They're tougher on than acute care, but I've seen it happen.
Yeah. Or leave it on their trolley and walk away from the trolley.
Yep. And we talk about that shortly. Yes. Controlled drugs, the S8s. Really, really important. The one that can get you into trouble the most. Right? So it must be kept in an above ground safe. I'm not sure why they specify above ground, but constructed of steel with a steel plate door, right? At least 10 millimetres thick. And if you look at it, it's got to be back to a wall and one side to a wall. So it's got to be in the corner somewhere. No? So a lot of them aren't. There's a lot of non-compliant safes out there. Right? Must have a pick-proof lock. Most of them do, or tamper-proof combination. Don't have combinations as much because people forget combinations. Must be installed with its back to at least one side flush with the walls of the building. And at least one side. So two parts have got to touch a wall.
A wall. I know.
I've seen it in most acute hospitals it is.
What's the keys?
The keys to the safe are to be held
Oh
with
my
the
God,
most.
how many times have I given the keys?
Yep. And but that's kept with. Given the keys to get your drug out's okay. It should go back to the most senior nurse, but I don't know how many times I've heard it. Anybody got the red keys?
Yeah.
You know.
Yeah.
Yeah. And and someone's got them who's not the most senior nurse.
He's on
Yeah.
placement.
There used to be doorbells. We used to press a doorbell because they would ring through the whole department and they knew to
Looking
bring
for
it
the
back
keys.
to the nurse's station.
Yeah. Wow.
Yep. And keys get lost.
Oh yeah.
And at the end of the day, if that key gets lost, the senior nurse is actually responsible.
Liable.
They don't realise it always, but they are. And if drugs go missing, they become responsible because they're supposed to have the keys. Because if someone's given to someone, they go and take some drugs out of the safe, are they going to admit to it? No. So, accessing the controlled drugs from the safe for an individual patient requires two nurses. Two registered nurses, or a registered nurse and an endorsed enrolled nurse to check. A registered nurse or medical officer. They can all check them, not a pharmacist. They can check them in, they can help check them in, but they can't actually check them out to give to someone. Not in their role. But it's always, and when you check a drug, particularly an S8, you should go to the bedside. Even though you've checked it in the book,
Do it again.
straight to the bedside with the person with the drug. There should be two of you at the bedside to administer that drug.
Yeah.
Because you signed for it to say, not just that they've taken it out of the safe, that they've administered this
Yeah.
drug. How do you know unless you see it that it's administered? Okay? Controlled drugs, which are securely stored but not in use, must be returned to the pharmacy as soon as possible. So, a lot of hospitals still hold drugs for months and months and months and never use them. In ED, we used to go through about once a month and clean out anything that's not been used for a month, back to pharmacy. The pharmacy don't like having to go through the process of giving them back out, but we used to get rid of them. All controlled drugs must be checked at the beginning and the end of each shift by 2 registered nurses or the qualified prescriber or pharmacist. They can check that they're there, right? But they must be checked. It's normally the 2 nurses that check it. Doesn't happen in a lot of places, aged care. But in acute, I can tell you now it does happen. It's really strict.
Because it's on a much larger scale?
Yeah, not just that, even on small wards. But because, particularly with SAIDs, there's more risk and vulnerability to it going. And you are made accountable. And the drug register that you check it in is not owned by the hospital, it's actually owned by the police.
Oh, right.
They actually control it. They can come in and take that and check it anytime they want. They don't need a warrant, they don't need anything. That's why it's like that. And they will check the DD register.
Wow.
I did not know that for many, many years until the police came in one day. We had missing drugs. Didn't know about it, and they took every register out of the hospital to check every drug where this person had worked. And they just said, start a new one. This one's closed.
Yeah.
Take your count off the top, we're taking the book.
Wow.
And you can't tear out a page.
No, yeah.
That's as bad as not having the drugs there, because they're all numbered. And you can't, if you cross out something, you have to leave a line so it's clearly read and explain why you've crossed it out. So medications must be stored in an individual residence containers in a locked storage facility, trolley or cupboard. Right? No sharing. You can't, because Mr. Smith's run out, you can't borrow Mrs. Jones's drug and give it to Mr. Smith technically. That's best practice. It happens, I know. Medication trolleys must be never left unattended when unlocked. All medications must be clearly labelled with a resident's name. Any items which are not named, get rid of them. Because you see little old ladies, and I've seen it lots of times, bring in their little box, their little medication pill box, normally very pretty, and they've got the pills they take for the day in there. They know what pills they're going to take, but no one else does, and they don't know what the pills are. So we can't give them to them. If they're not name marked, get rid of them. Let the doctor order new ones and use them from our stock. If they're in clearly marked boxes and they're in date, maybe. But it's still in acute, we still prefer to use our own stock. We know where it's been. And you as a nurse, if you're giving something, you want to know it from a safe source. Okay, no medication is to be shared per clients, fair enough. Not even if they want to share it themselves. Try some of mine, George, I've seen that. No, don't do that. So, these work better than yours. They're gorgeous, but wow.
Yeah.
So, not left on the bedside.
Yeah.
Right, when we're giving them.
Yeah.
They should actually watch the patient swallow. How many times you've left them with their meal and walked out. Patients must be able to, if they can administer to themselves, let them administer it. I am not demented, I am not old, but I go into hospital and I get nurses that want to give me insulin. I'm pretty sure I can read the dial on the insulin needle. I'm pretty sure that I know how much insulin I should take. I'm happy for them to sit there and watch, but they insist they want to do it themselves.
And they hurt when they do.
And I have a system. I rotate my insulin sites.
But in case you are,
No.
would you would it be okay?
If I'm unconscious, that's okay. I'm cognitively impaired. I don't care. Won't matter to me.
Yeah, but if you're in hospital and
If
you're fine,
I'm awake and alert
Do it themselves.
and I'm meditating well, I should be keeping in practice anyway.
But what happens if you make a mistake?
Well, they watch me self-administer it. If I make it, they'll check it
Oh, they will.
I'll
That's
show
what I was
'em.
wondering.
and say, look, I'm giving myself 24
Okay, that's what I was
units
wondering.
and I'll inject it.
Okay.
They can check it, but no an issue.
Yeah, and then they
Yeah,
take
okay,
it
that's
away
what I was just
anyway,
wondering.
once you've done
And
it.
you write self-administered,
Okay.
S and a circle round it for self-administration, and off you go.
They will look at that. That's why.
Edwin did it.
I don't like anyone in doing leave, I know.
So, following appropriate verification that the administration has occurred, self-administered. I think it's S in a circle.
Yeah.
Recorded on the med chart. Medications must be signed for by administering staff immediately after they've administered it. Jade teaches a really good system over there. You put a dot when you put it into your cup or take it out, and you sign for it after you've given it. Why would you only sign for it after you've given it?
So you know that they've done, they've had it.
And then if you get called away.
Yep.
If you get called away,
You get a
know where you're
cardiac
at to.
arrest, you forget you've signed it. Oh, I've given that, don't worry
Yeah.
about it. Right? Oh, then 4 hours later, oh, I didn't give that to Mr. Smith. Too late.
Yeah.
Bagging.
So, only EEN, I've got to change the term, I keep saying it. Only registered nurses and enrolled nurses who have the appropriate qualifications can administer medication. Drug schedules. There are 9 schedules, one's gone. So it starts at S2 now.
Okay.
S2, S3, 4 are the ones most commonly administered by enrolled nurses. S8 not so commonly, but they are sometimes. S2 are the therapeutic poisons. They're available without prescription from pharmacies
Or
or licensed poison
Who's the
retailers.
retailer?
Yeah.
Who's the licensed poison?
Most hardware stores.
Oh.
They can sell rat poison
Oh, I see.
or weed killer.
Okay.
They're licensed poison retailers. Because you have to have them in a safe place.
Yeah.
And-
I get it.
The rodent people, you know, the come and the flick men.
Yeah.
They're licensed poison users and retailers. S3 are therapeutic poisons available without prescription from pharmacists who must establish the patient's therapeutic need. They're the ones you've got to produce your driver's licence for. Cold and flu caps.
Yeah.
Sudafed.
Yeah.
And like-
Sudafed and
Yeah. Because, and
yeah.
particularly
And they put
Sudafed.
a label on it.
Yeah, if you want pseudoephedrine of any type, you have to produce ID because they use it to make ice.
Yeah.
S4 is restricted drugs available in pharmacies with a prescription. You have to have your prescription. Okay? They have to keep the records for 2 years. Panadine Fort's common.
Yeah.
S8, you know what your S8s are? Drugs of dependence, addiction. 7 rights. You'll see this through the way. Remember, you can't go wrong if you do your 7 rights. And you check. Time for a break.
That's lovely.
Have a 5-minute break.
Yep.
Get yourself a cup of tea.